My name is Dr. Clement Nzuka. Today, I will be looking at 3 nightmares often confronting healthcare workers. One is a palpitation. Palpitation is a nightmare to a cardiologist because he doesn't know where it comes from. Backache is a nightmare to an orthopedic surgeon because he doesn't know where it comes from. Headache is a nightmare to a neurologist because he doesn't know where it comes from. The first question, that's the one I will be talking about today. I'll be talking about a headache. Headache. The neurologist doesn't know where it comes from. Is there, he asks himself or herself, is there a serious underlying condition here or underlying illness? He asks himself that. And he comes to terms when he thinks of, if there's a serious underlying condition, then I'm going to look at its onset. If it's sudden and abrupt, sudden, with a severe headache, then there's an underlying condition here. There's an underlying illness here. Whatever it is, still needs to be investigated. But the sudden onset with a severe headache. Number 2, if the headache is accompanied by a fever, if the headache is accompanied, because I don't know where it comes from, if in the fever, what generates the fever, I don't know. But the patient is having a headache and it is accompanied by a fever. Temperatures of about 30, 39, 38, 40. Remember, normal temperature, 37 degrees C. Now, we have a 40. And the patient has a headache. We don't know where it comes from. We don't know. But we say there's an underlying condition here, if that is the case. Again, if the headache is accompanied by an impairment of mental status of the patient starts losing it. Patient starts getting disorientated. When the patient is like that, then we know that there's an underlying condition here. If the patient, if the headache is accompanied by seizures, convulsions, then there's an underlying condition here. If the patient has got a focal neurological problem, like a hemiparesis, a hemiparesis can be left or right. You start asking yourself, is there a stroke here or something? So, if the patient has got those, then we say there's an underlying condition here. There's an underlying illness. It doesn't matter what it is. You know, I'm forced now to talk about those conditions which could be underlying. In other words, a headache that is accompanied by certain conditions, important conditions to consider. What are you going to think about? I'm going to think about, that's a neurologist. The neurologist says, is there, there are these space-occupying lesions like a primary brain tumor. When you say primary, you mean to say it starts in the brain. It starts there in the brain. That's why you say primary brain tumor. It starts there in the brain. Because it could be that the tumor comes from another area of the body. It could be coming from the lungs, coming from prostate, coming from the, the kidney, coming from wherever. And it goes straight to the brain, and it causes a headache when it gets to the brain. We call that a metastatic, because it has spread from a certain area of the body, and it has spread to the brain. And so this one is a metastatic brain tumor. The first one was a primary brain tumor. This one is a metastatic brain tumor. What are the space occupying conditions like a brain abscess? That's a space occupying, and it's always accompanied by what? By a headache. Brain abscess, a brain abscess. You can imagine a brain, an abscess developing right in the brain. Caused maybe by pus-forming bacteria. You understand that? So it could be. Which are the space-occupying lesions that could be there? Hydrocephalus, for when the CSF, or the cerebrospinal fluid, the one that always there around the spinal cord and the brain, that fluid is called the CSF, or the cerebrospinal fluid. If it gets obstructed somewhere, it causes what is known as a hydrocephalus. Hydrocephalus can be accompanied. That's a space-occupying lesion that can be accompanied by a headache. Which are the space-occupying lesions that you think of? Oh, I'm humbled by this one because I once suffered from it. Subdural hematoma. The dura. There's the duramid, there's the pyamid. Subdural hematoma. If a patient has a subdural hematoma, that is accompanied by a headache. But surprisingly, maybe mine was treated fast, because I didn't present with a headache. I presented with something else. Right. So subdural hematoma, that's the main thing. Subdural hematoma can be accompanied by a headache, and that's something serious. But what else? Which other space-occupying lesions can you think of? What about subarachnoid hemorrhage? Subarachnoid hemorrhage can present as a headache, and those are serious. One to actually diagnose it, one has to do all these brain CT scans, MRIs and all those, to say that, oh, there's blood in the subarachnoid space, and that is accompanied by a headache. What else? Space occupying lesions, like for instance, intracerebral hemorrhage, right in the cerebrum. Hemorrhage, those blood vessels, they get ruptured somehow. Maybe there's an aneurysm that is burst or something. But bleeding in the cerebrum. Those are space. What else can cause it? They can cause a headache. If a patient has got meningitis, a patient has got a stiff neck, patient presents with a stiff neck and a headache because of the inflammation of the meninges. That's called meningitis. So those are serious conditions which can present as a headache. So that is why it is not my patient at all. I'm an OPD doctor. I can't deal with that. I've got to refer this patient to the physicians. I've got, because they're going to do quite a number of things. They'll do a lumbar puncture to establish whether this is a meningitis or not. And they'll be able to classify it. What type of meningitis is it? Bacterial meningitis, viral meningitis, whatever, fungal meningitis. They're able to do that. But I'm saying meningitis can be accompanied. Patient will present with a headache. Present with headache when the patient has meningitis. What else? There's something called optic arteritis. No. In the temple, there's this temporal area. Temporal area has got arteries there. When they are inflamed, it's called temporal arteritis, and it presents as a headache. Temporal arteritis. So the headache will be accompanied by this lesion, temporal arteritis, inflammation of the arteries in the air in the temporal region. The very last one I would like to mention: if a patient has got glaucoma, pressure right in the eye, damage is right in the eye, that patient will present with a headache. Those are and all those conditions that I've just mentioned. Glaucoma, for instance, will be diagnosed by an ophthalmologist. That patient, so in other words, that patient is not mine. I won't keep that patient in casualty, or I won't keep the patient in casualty, and I won't keep the patient in OPT or discharge the patient home. No. I'm going to refer the patient. Glaucoma, I'm going to refer to an ophthalmologist. All the others, I'm going to refer to the physician so that he can meet up with the neurologist. Right now, I just want you to follow me and you tell me if this is your headache. You are less than 40 years of age. Less than 40 years of age. And you have this type of a headache. A headache that starts with changes in the mood. The patient starts having nausea and vomiting. The patient starts being sensitive to noises and all that. The patient loses appetite, develops what is known as anorexia. Doesn't like food. When the patient, used to like food, or still is a patient who eats well, but now it starts loses appetite. That is called a prodrome. Because nobody's complaining about pain. No. It's just that the patient develops nausea and vomiting. Patient develops anorexia, doesn't like food. Patient has got mood changes mood, and now this is now. Just when we are observing that, no complaint at all. That's called a prodrome. But the patient starts developing now sensitivity to light, doesn't like light. They call it photophobia. Doesn't like light. Dodges light and all that. Doesn't like light. And the patient develops a condition where, there are sensory abnormalities. It doesn't like sounds. The normal sounds that, he normally hears my voice and all that, but now becomes sensitive. This is called phonophobia. They don't like sounds. First of all, it was photophobia. They didn't like light. They ran away from light. This is now not a prodrome, but it's called an aura. Once there's that photophobia, in other words, running away from light and being sensitive to light, running away from sounds, wants to be alone, doesn't want to be with other people he thinks people are making noise, phonophobia, that's your aura. Started with the prodrome, and they're coming now to an aura. Just when we are observing that, patient running away from light, patient not liking sounds and all that, just when we are there, the headache starts. And it starts on one side of the head and the face and the neck. One side. It's It's a unilateral headache. It starts there. It's a dull pain. Nobody talks about it. The patient does not even complain about it, but notices a dull pain, dull pain, dull pain. And it's not even going to take treatment. There's nothing. I mean, it doesn't need treatment because it's a dull pain. It's just if the patient was working, he'll continue working, or she will continue working without any problems. Just when we are on that, the patient graduates from this throbbing headache, graduates to a throbbing headache, a pulsating headache, a throbbing patient. Now the patient says, no, is there any Panadol around? Is there any analgesic that I can use? Is there any aspirin that I can use? Now it's a throbbing headache. It is a pulsating headache. You remember a unilateral headache. It's pulsating now. It's throbbing. So now the patient needs something to take, an analgesic, something to quell the pain down, something to make sure that the pain is controlled. Just when we are on that, trying to give treatment, trying to give our Panadols, giving our aspirins and all that. Just when we are doing that, the headache becomes incapacitating. So it's graduated from a dull pain to a throbbing pain. Now it's incapacitating. The patient can't do anything. If the patient can't work, patient can't do anything. Now, this patient becomes a hospital case. Patient must be rushed to hospital. There's no way, because the patient now it's like a disabling sort of pain. This is incapacitating. This headache, and then just when everybody is preparing, let's take this patient to hospital. There's no way, we can't deal with this at home. Just when this patient must be seen by the specialist now, what is happening? The patient headache stops. Termination of headache. What's going on here? Termination of headache. Termination of headache. Yes, termination of headache. So the first step was a prodrome. The second step was an aura. The third step was the beginning of a headache, dull ache, a dull pain that graduated from a dull pain to a throbbing pain, to a throbbing headache, pulsating headache. It graduated from that to become incapacitating. No, we can't stand this at home. We must take the patient to hospital. Just when you are saying you're taking the patient to the hospital, the patient, the headache of the patient comes to an abrupt stop. It terminates. Termination of the headache. And after that, there's that hangover period. That hangover period is known as the post-drome. This whole headache, which starts from a prodrome to a post-drome, is called, given a special name, it's called a migraine. You get it with all patients who are less than 40. Your daughter at teens, your daughter, your son will develop this headache. And then you should know that this is a migraine. This is a migraine headache. And this is, it stops when you have a prodrome, that hangover phase. The patient is just dull there. There's no, you don't treat the patient, you just say the patient must just lie down and all that. But what I would like to say to, I'm sure you want to know, is there anything that can be done with this agent? This is a migraine headache. Is there anything that can be done with this headache? The answer is yes. People take what is known as prophylactic therapy. Prophylactic therapy. What prophylactic therapy are you talking about? I'm talking about tricyclic antidepressants. Amitriptyline, nortriptyline. I'm talking about those. Take them at night. You start with 25 milligrams of amitriptyline at night, bedtime. Just take it as prophylactic therapy. What else do you take? Is that all? That is not all, definitely. These patients take a beta blocker. These patients take a calcium channel blocker. These patients take sodium valproate. Sodium valproate is ioepilene as prophylactic therapy. Whilst I'm there, maybe I should just mention the other types of headaches. This is just prophylactic therapy. Maybe I should just mention the other types of headaches that can be there, that can be found there. This headache, you will tell me if this is your headache. It's periorbital, or sometimes behind the eye, just behind there, and it's hacking. This is what is known as a cluster headache. Right on one eye, it will be there, even behind the eye. That's a cluster headache. Cluster headache. Is that all? Is that all? There is another type of you place yourself. You say, this is my headache. Cluster. This is migraine is my headache. Cluster headache is my headache. Or the other types of headaches, those that I mentioned earlier on. But listen to this one. There's this headache that forms a band around the head. Bend. It will be in the occipital area. It will be right in the occipital area, occipital right there. It will go in the temporal area. It will go the frontal area. Right around it forms a band. That's called a tension headache. Tension headache. So you have a cluster headache. You have a tension headache. You've got spinal tap headaches. What are those spinal tap headaches? When you've just done a lumbar puncture, you've pulled this CSF, then the patient starts to have a hacking headache. That's a spinal tap headache. Is that all? No, there are other headaches, like for instance, post-coital. It's like they call it post-coital headaches or post-coital cephalgia. And this headache is the type of headache that you will have. All young people, they'll have whilst having their partners, and during the act of intercourse, before orgasm or after orgasm, they experience this headache. What we are worried about this headache? Well, that one goes away with some aspirin, tricyclic antidepressants and all the beta blockers. It goes away. But what we're worried about it, I'm mentioning it because if there's an outpocketing known as an aneurysm in the brain, and then this outpocketing or this aneurysm leaks into the subarachnoid space, and that is accompanied by headache, that is serious. The patient has got to go to hospital. But that happens with post-coital cephalgia. Okay, but there is another headache. When there's intracranial hypertension. Intracranial hypertension, you say, there's an increase in the intracranial pressure. but there's no malignancy. This is known as, there's no malignancy at all. There's no primary tumor there. There's no hepatic tumor, or sorry, there's no, shall I say, a tumor that is spread to the brain. Metastatic tumor. There's no metastatic tumor. There's nothing. There's no malignancy. But there's an increased intracranial hypertension. This is given a special name. It's called pseudocerebri tumor, pseudotumor cerebri, or pseudotumor cerebri. So, in other words, there's no tumor. It's just an increase in the intracranial pressure, increase in the intracranial hypertension, and that is called pseudotumor cerebri, and that's accompanied by a headache. I would like to say something about your giving beta blockers, your giving calcium channel blockers as preventative measures, or as means of aborting a migraine. You know, to try to abort a migraine, you think of a beta blocker. But there's a beta blocker that is very good and safe. It's regarded as being safe. It's called propranolol. 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 Propranolol, if you take something like 80 milligrams of that, it does well. You can even double it, make it 160 milligrams, but you have to watch out. Watch out for your pulse. Your pulse must not go lower than 60. Remember, if it goes lower than 60, that's a bradycardia. So you don't want to precipitate a bradycardia. But that you can watch out. You don't have a problem with that. But what is problematic when you're giving a beta blocker is that beta blockers, one has to be worried. There are two types of receptors. A beta 1 receptor and a beta 2 receptor. Beta 1 receptor is right in the heart. And you'd like your beta blocker to be cardioselective. In other words, go to the one in the heart, to the beta 1 receptor, and not to go to the beta 2 receptor. Beta 2 receptor has got a problem of a bronchospastic attack, where the patient just gets like a respiratory distress. The patient can even go into respiratory failure. So you don't want that. You don't want to precipitate that attack, a bronchospastic attack. You don't want that. And that can happen if you are not selective with your beta blockers. Like I was saying, propranolol is a very good one. But propranolol is not known to be cardioselective. And so patients have got to be chosen, so to say. I can give it to this patient, but if a patient has got a history of asthma, a patient has got a history of COPD, chronic obstructive pulmonary disease, because that one has got a bronchospastic component. We don't want anything that has got a bronchospastic component, like asthma and all. You don't want that. Because if you give a beta blocker, when there's a bronchospastic, you are precipitating a respiratory distress, which can result in respiratory failure. You don't want that. The patient dies because of what you've given. You don't want that. Thank you very much. Thank you very much. Thank you very much.